work on P16, which is probably the best published gene silenced by methylation. We got a number of 28% of tumors, a little bit less than some of the MSP literature. I visited Ralph Krahe when I was in the MD Anderson, and Ralph actually was the first person to describe pyrosequencing for the use of methylation assay. I want to give Ralph the credit for that. But Ralph's figures on a different set of head and neck tumors in a different city, in a different country, using a different part of the promoter, were basically the same as ours. So for the first time, we sort of believed it. So we put all this data together, all of these genes we looked at, which were just effectively picked from the literature. And we looked at them, and we thought, well, so what? And then I asked this question, does methylation of one gene promoter predict the methylation of others? So when we put our information together, we discovered there's a series of highly methylated tumors and a series of basically unmethylated tumors at the tumor suppressor genes we looked at. And my statistical colleague, Derek Lowe, told me this was a real association. It wasn't just random distribution. And then I realized this was an old field. This is somebody else's field already, but in colorectal cancer. And this CpG island methylation phenotype, or CIMP, has been described really extensively in colorectal cancer. And the methylated tumors have certain characteristics they associate with the older patients with KRAS mutations and increasing stage. Jean-Pierre Iser is very active in this field, and he's basically defined this CIMP. And it's interesting, one of his comments is that this CIMP is a molecular signature associated with inflammation-mediated cancers. And I'll come back to that in a moment. But I realized that this CIMP had not been reported in head and neck, so I thought we'd better get there before Joe did. So was there a phenotype? Was it prognostic? Was it predictive? And what we found was the CIMP-positive tumors were less aggressive. We went back to our Rolls-Royce database. This is the jewel in the crown of our unit in Liverpool. And we were very, very quickly able to see that these tumors were behaving a little bit differently. They had less lymph nodes, they had less tumor depth, and there were trends for all sorts of things that were clinically relevant. And I'm very pleased to say that one of the prizes has been given to a paper that's in press in the British Journal of Cancer from the Gustave Roussy. And they've looked at some methylated tumors and unmethylated tumors, and they found this same prognostic association. And it is one of these things, you kind of don't believe your own work until somebody reproduces it in a different center using different techniques, and then it seems a bit more real. And congratulations to Hang Tan for that prize. So why was this prognostic difference? Well, we looked at Anaroth score. In fact, we took these tumors and we took these tumors, we shuffled them up and we gave them back to our pathologists, Julian Hall and Julia Woolgar, and we said, right, let's really go to town on this Anaroth score. What's the difference? And the difference was all in the inflammatory response of the host to the tumor. So this is what we saw in a CIMP-positive tumor. We just saw white cells. And this is what we saw in the CIMP-negative tumor. Almost negative inflammatory response. And this got us talking. And we found ourselves in a field that we didn't know anything about, and we didn't know anything about how to study. So, was it methylation that had caused the inflammation? Was it methylation that had arisen within was it a tumor that had arisen within an inflammatory lesion? And we don't have the answer to that question necessarily. But this association with cancer, inflammation, and epigenetics is quite intriguing. Quite clearly, the association with cancer and inflammation is very real. And I've been standing here for 10 minutes already telling you cancer is an epigenetic process in part. And there are some interesting reports about the fact that inflammation is epigenetically mediated. But what about in the middle? And I thought, well, what we've got to do is we've got to look at more tumor suppressor genes, we've got to look at more methylation targets, and we're going to have to invest some money in array. So I did something that's well, I did the most expensive day's laboratory work that I'm going to be doing for a long time, and we bought the new Illumina array for methylation, which was just available, and we put our samples across it and had a look at the results. And immediately you're going to say, well, this Richard Shaw's a fraud, because some of the samples are basically methylated, and the methylation is constant, no matter what the sample is. So red is methylation. And the green samples are unmethylated, and again, it seems that like the upper three-quarters of this heat map really call against this methylation phenotype. But it does come down to the selection and the choice of selection for the genes that have gone into this array. And I think, although Illumina have never told me, that they've basically crawled the web, anything that's ever been described as a methylation variable region, whether it's embryology or cancer or what have you, and put it on. And I think that these are basically imprinted genes, and we would never expect to see a great deal of variety in a cancer process. But of course, looking at the bottom of the slide, there's actually some action here, and expanding that action up. We realized that perhaps before we go too mad looking for methylation phenotype, we might be able to find some markers of biological aggression and something a little bit more useful. So this is the bottom part of the heat map expanded up, and quite clearly there are different signatures and there are different clusters. And when we're thinking of what's the most clinically relevant problem, we've just published a series of 560 oral cavity cancers treated in Liverpool over a 10-year period. Now, oral cavity cancer has increased by 25% in the last 10 years in our country. And the most prognostic factor was extracapsular spread. And we're really failing these patients. The lymph node negative patients, we've got increasing survival year on year. But the extracapsular spread remains a serious problem. So, for example, how many of the tissue samples and various tumors show methylation in normal mucosa versus a lymph node negative tumor versus a lymph node positive but not ECS versus the bad ones, the ECS patients? Is there anything useful we can pull out of this? So I'm just going to show you some of the hits that we've looked at further. And when you get these hits, what you really want to see is one or two old friends that maybe have been published before, and maybe one or two new things that you can make your name with. That's what you'd really like. So DCC, you're thinking, well, colorectal cancer. But once again, Joe has published this paper, and DCC was one of the few genes that not only was really closely associated with cancer, the methylation, but also when you reinstalled the gene with transfection, it just killed the tumor dead. So DCC appears to have a real role. I don't think that had been realized before this work that Joe did. So I was very pleased actually to see that DCC was effectively unmethylated in normals and was strongly methylated, 85% in our most aggressive tumors, and this pattern in between. HOXA5, I was sort of vaguely aware of HOX genes in differentiation, but I found that, in fact, the chap who examined my thesis, Bob Brown, had taken some samples from Liverpool of chronic myeloid leukemia, and HOX gene methylation had this correlation, and in chronic myeloid leukemia, hypermethylation of HOXA5 was strongly correlated with progression to blast crisis. And I thought, this is fantastically interesting, that just these genes that just spin out of this array experiment seem to have an interest beyond head and neck cancer. So this remains work in progress, and quite clearly this has to be validated, biologically validated. We'd like to correlate it with expression. And we may learn something about the mechanism of ECS and metastasis by this route that wasn't available otherwise. And I'm going to talk a minute about biomarker studies just to finish. But it's quite clear from this preliminary work that, of course, we'd also like to be looking at radiosensitivity, chemosensitivity, tumor hypoxia, and host response. Bimethylation, this is a new area, a new avenue of investigation that's available to us. And, of course, HPV-mediated tumors, are they different? And, of course, epigenetics is amenable to therapeutic intervention. There are DNA demethylating agents, histone deacetylase inhibitors in phase 1, 2, and 3 trials in hematological and solid tumors at the moment. So from my point of view, the interest is that DNA is robust, and some of our previous work that's been done on metabolomics or proteomics won't be directly transferable to a patient sample in the real world, because you can find that you're measuring Monday and Tuesday if you're not careful, rather than real differences between tumors. And I've got a certain amount of faith in DNA-based assays, provided they have biological use. The other thing about methylation assays, they can be made very sensitive. So they're ideal for assays in surrogate samples. So you may be looking at saliva for head and neck cancer or urine for bladder cancer, because you can detect methylation 1 in 1,000, 1 in 10,000, and so forth. The other thing is next-generation methylomics. It'll come with next-generation sequencing. It's just starting now. It's going to completely blow apart everything I've been saying for the last 20 minutes, and then we'll really find out. And maybe I'll come back in 2012 and present that data. So back to some of these more grounded, feet-on-the-earth biomarker studies that I've been having a little bit of fun with in Liverpool. So we went to this story of the surgical margin analysis. So we'd got the data for the tumor and normal surrounding tissue, and we thought, well, what happens if you look at serial sections through a tumor, methylation of a number of genes? And what we found, it was remarkably constant to the edge of the tumor. And then we thought, well, beyond the tumor, you'd expect it to go to 0. If it's tumor-specific methylation, it should go to 0. And that might be an interesting way of staging the tumor to see whether you've actually removed it. So I'm going to present some highly cherry-picked data from my paper on this. And so we had this tongue tumor, the commonest site in our practice, and we had tumor, margin, intrinsic tongue muscles, nice clear margins. And our pathologist told us we'd done a good job, and we had this 7 or 8 millimeter margin, no problem. And we found that this tumor was informative for P16 methylation and cytoglobin methylation. And basically, the intrinsic muscles that we looked at were clear, and the patient survived and had no recurrence. And this other tumor, similar size of tumor, and we had tumor going into the buccal fat from the retromolar. And again, our pathologist told us we were clear. But what the molecular assays showed us, there was a decreased level, but a level nevertheless of methylation in the fat beyond the surgical margin, and this patient's got recurrence. So this isn't a particularly new phenomenon, and this has to be applied clinically. If it's, we have to see where this is going. And our data was really just a pilot data, proof of principle using our pyrosequencing assays. And there are others in the field. There's the Italian group, there's Joe and the John Hopkins group, and there's this paper from Gustave Roussy in Paris. And I think I'm far from threatened about this. I think it's nice that there are now 4 groups really pushing the side of methylation surgical margin analysis, because I guess by 4 groups we'll find out whether it's going to be any use or not. I'm going to finish by talking about oral dysplasia and premalignant lesions. And the clinical literature, nice paper by Holmstrup, has really said unless there's a lot of red area, or it's a very large lesion, or it's PVL, it's difficult to call whether you should remove these lesions, whether they're going to progress. And it's a very active field, because the assumption is that if we find the changes that are critical in these dysplastic lesions, they may also be the critical changes in invisible molecular field change, which might have a wider implication for cancer screening, and furthermore into lung cancer screening and esophageal cancer screening. Now, I was trying to convince you that epigenetics is involved early on, in the early stages of cancer development. So it made a lot of sense maybe to look at methylation of our dysplastic samples and to see whether it was predictive. So we aimed to explore the predictive value of a panel of biomarkers, and we used the ones that we knew and we'd studied in our own lab in a cohort of patients with dysplasia. So we had this long-term longitudinal study, 130 or so patients with many, many samples, and we picked out the ones that had a definite histological diagnosis of dysplasia. And we wanted 5-year follow-up data, so I only recruited the patients for this trial from 2000 to 2003, thus they had 5 years follow-up. And we wanted at least 3 samples per patient, and we wanted to know the outcome. We had to have seen them recently. So I was fairly strict about this, and I worked on this with one of our pathology colleagues, Julian Hall. So of course we got a group of non-transformers and transformers. So the samples we took, interestingly, some of you may recognize this if you've done colorectal surgery, but we found this was an extra, they're made very cheaply with a little sharp edge, and they basically allow you to just lift cells off, and you get plenty of DNA from the lesion. And this is the way we went. And we compared the pattern of microsatellite changes in the samples to the biopsy, and we found it was very similar. So we guessed the same would be true for methylation. And the assay we used is something that sort of a home-cooked assay, which combined the advantages of methylation-specific PCR, i.e. sensitivity, with sequencing to check that the product is actually methylated, because you're tempted to get more and more sensitive and you lose specificity if you're not careful with these PCR reactions. So the first thing to say is we were a little bit disappointed to find we only had 14 transformers, and we matched them with a group of 24 non-transformers within this cohort 2000 to 2003. But I am reassured by looking back at some of the best papers in this field which have even smaller numbers. And what we found was, in principle, is that some of the genes we're looking at, cyclin A1 and MGMT, were a little bit disappointing. There was a little bit more methylation in the transformers to the non-transformers, but the P16 result was quite striking. In effect, only 2 out of 284 scrapes were methylated in patients who've not yet got cancer. So P16 methylation was very specific for malignant transformation in our hands, although about 50% sensitive. So we thought this was very interesting. Does it make sense? Well, I guess it does, because P16 is known to be very important, and one of the most predictive changes in terms of genetic changes is 9p21 loss. So maybe there's a story about 9p21 losses and P16 methylation, which will really unlock this field. Interestingly, we found the DNA methylation was present in our control scrapes from unaffected areas almost as often as our lesions. And this is the data, but in principle, 2/3 of the positives were in the dysplastic lesions, but 1/3 of them were in the scrapes. And we thought, well, this may be two things going on here. It may be that the field is much bigger than we think, or it could be that we're picking up DNA methylation in cells floating around in the saliva, picking them up with our spoon. And we don't know the answer to that. But to me, it's opened up the field for looking at mouthwash and saliva, perhaps more than scrapes, because our assays are sensitive enough and the field is wide enough. I think that's what we've shown. So there was concordance also between the scrapes and the biopsies. So a percentage, a minority of these, we actually had a snap frozen biopsy from the same lesion as a scrape, and there was reasonable concordance. But again, where there was a difference, there was more methylation in the scrape rather than the biopsy, because I think the scrape is picking up saliva and probably picking up methylation from elsewhere in the mouth. So I'm going to finish here. This is really survival of the fittest. This is, if you like, my hypothesis, a little bit cheeky based on a little bit of data perhaps. And I don't really believe this until somebody else reproduces it. But if we can say that the normal cells become a little bit more like cancer by p16 methylation and gain a survival advantage, and then maybe methylation of other genes comes in, p16 losses, p53 mutations, ploidy in cancer. And this needs to be tested. But this importance of the epigenetic field, I think, requires some further research, larger studies. We need to look at more genes. And I'm going to finish there. I think I've probably used my time up. I hope I've told you a little bit about the basics, the way I understand it, which is very simplistic, about epigenetics and cancer, explain the difficulties and the advantages of some of the assays, and perhaps some of the practical applications and the future applications of this field. I'm going to do my thank yous. This has been funded by Cancer Research UK, the British Association of Oral and Maxillofacial Surgeons, and the Research Department of the Royal College of Surgeons of England. I particularly want to thank my colleagues and my previous trainers and now colleagues in the Regional Maxillofacial Unit at Aintree in Liverpool. We now have a faculty of 13 maxillofacial surgeons across the specialty, and in fact there's 9 surgeons across skull base, ENT and maxillofacial who pretty much restrict their activity to oncology. I'm going to single out a couple of individuals. First of all, James Brown. James has been my surgical mentor and one of my research mentors, and I think without James Brown and Simon Rogers I wouldn't be stood here for sure. James, I think, has done the pretty much definitive work on mandibular invasion in oral cancer and the management of the mandible. He's also done, I think, pretty much the definitive work on mid-face reconstruction. And I'm very grateful for James for all the encouragement he's given me over the years. He now has the misfortune of operating with me on a Thursday, which he's regretting. Simon Rogers, some of you will know, and Ernie knows very well. Simon's just been awarded a well-deserved chair, and his field is quality of life research, and already has over 100 published papers. And Simon's taking on the challenge now of turning the thing around and trying to drive the clinical trials by quality of life, which is what's needed in head and neck, I think. Of course, we have a clinical MDT, a multidisciplinary team, what you call a tumor board. And our clinical MDT is now about 40 strong. It's a real rabble. But myself and my ENT colleague, Terry Jones at the university, we've forced these unwilling and various professors of science to come in with us, and we've made them do head and neck cancer. And in particular, I want to thank Janet Risk and Lakis Laloglu, who've helped me enormously and supervised me when I was doing my research, and now are willing to continue working with me. And give credit to Julian Hall, who's one of our pathology trainees doing a PhD in the group, who did all of the work really for the dysplasia study. I also want to thank my wife, because I usually forget that, and I got into trouble, but I'm not mentioning her on the first page of my thesis, so I've done the good thing here. And Gillian's here today, and we'd both like to thank the American Head and Neck Association for making us feel like royalty. And we really have enjoyed San Francisco, and we've enjoyed this conference. This conference is without a doubt the best conference of any type I've ever been to in my life, and we're very grateful. We've got a big group from Liverpool here this time. I think there's 12 of us, and we've had a great time, so thanks. I guess it's no surprise, because the president and conference chair, and getting to know them a little bit is no surprise. And something James suggested to me, we started actually calling this quadrennial meeting, we can't say quadrennial, so we call it the Head and Neck Olympics.
Richard, thank you very much for educating us on epigenetics. We appreciate all that you put into this, and on behalf of the Society, please take this certificate.
Thank you very much. Thank you. Thank you very much. Thank you.
And now it's my pleasure to invite Andre Carvalho to make the next introduction. Andre?
Ladies and gentlemen, it's my honor to introduce Dr. René Leemans. Dr. René Leemans received his residence training in general surgery at Andreas Hospital and in otolaryngology at the VU University Medical Center, both in Amsterdam. The same university awarded him his PhD in 1992. He received, after this, a Dutch Cancer Society fellowship grant from 1992 to 1994 to further specialize in head and neck oncological and microvascular reconstructive surgery. This training was completed at the departments of otolaryngology, head and neck surgery of the VU Medical Center, then read by Dr. Gordon Snow at the Netherlands Cancer Institute in Amsterdam and at the Plastic Surgery Unit at Kennisburg Hospital in Glasgow, UK, read by Dr. Suter. Herefore, he joined the Department of Otolaryngology, Head and Neck Surgery at the VU Medical Center in Amsterdam, where he holds two rank positions and currently holds the chair of the department. He is a professor of otolaryngology, head and neck surgery, and the co-director of the VU Medical Center Cancer Center in Amsterdam. He is also the director of the otolaryngology residence program and the advanced fellowship program in head and neck surgery and oncology at the VU University Medical Center in Amsterdam, positions that show his commitment to teaching and his ability with leadership. He is a member of the steering committee and chair of the surgery subcommittee of the head and neck cooperative group of the EORTC and chair of the Dutch cooperative group on head and neck oncology. He serves on the board of the International Federation of Head and Neck Oncologic Societies, and he is a founding member of the European Head and Neck Society, presently serving as its first general surgeon. Besides, he is secretary elected of the International Academy of Oral Oncology and president elected of the Dutch Otolaryngology Head and Neck Society. This which shows his commitment with colleagues in the field of head and neck surgery. His special interest in the field includes head and neck oncology, microvascular surgery, and basic research, which can be proved by his authorship in more than 250 papers and book chapters on head and neck oncology. Furthermore, he is regularly invited to speak at international conferences and tutor at courses. He also serves as editorial board of 8 journals. If I may add this, I have been told from a head and neck surgeon that's now in an important cancer center and had the privilege to do a fellowship under Dr. Leemans' supervision that he is also a very talented and skilled surgeon. Without further ado, please welcome Dr. René Leemans.
Well, thanks very much, André, for this very nice introduction. I'd also like to thank the organizers for bestowing the honor on me of giving this first Milton J. Dance lecture. I have nothing to disclose. The subject of the end-node neck in patients with early staged lesions is not a new one, and indeed it has been the subject of many a conference. And also, every conference of this kind has devoted many of its time to the end-node neck. And just to take you briefly over the developments in elective treatment of the neck, I'd like to start off by quoting Hayes Martin back in the 50s, that it was illogical and unacceptable at that time weighing the morbidity of the treatment. Later on, when modified and selective neck dissections came into vogue, elective neck dissection, of course, became more and more acceptable. All in all, there have been only 3 prospective trials that address this issue, and they were very underpowered, but they failed to show any difference. In the 1990s, however, many were performing elective neck dissections because the selective neck dissection, supraomohyoid lateral neck dissection, was so easy to perform with little or no morbidity, it was said. Later on, we understood that the primary tumor characteristics could be indicative of lymph node involvement, and also careful and repeated examinations by ultrasound-guided fine needle aspiration cytology could help us in this respect to bring the number of elective neck dissections down, because we were then realizing that we overtreated the majority of our patients, which is certainly not a good thing to do. Sentinel node biopsy is a recent addition to the armamentarium, diagnostic armamentarium, and I will say a little bit about that. And now we also have an expression array study that could probably tell us whether the tumor is going to metastasize, yes or no. And these last developments I would call more patient-tailored approaches, which is of course in line with the current philosophy dictates. The rationale, just quickly to go over with you. Occult disease in the neck will inevitably develop into clinically manifest disease, and despite regular follow-up, some patients will develop inoperable disease in the neck with a wait-and-see policy, and this of course has to be avoided. And untreated occult disease in the neck may give rise to distant mets while the lymph node is growing to a clinically detectable size. These are all arguments in favor of elective neck dissection. Arguments against, as said before, it means overtreatment in the majority of patients. It gives increased morbidity, and especially with near midline lesions, when we have to do bilateral neck dissections, a certain morbidity cannot be avoided. And indeed, some presentations during this conference as well have alluded to that. It increases operation time and costs, of course, and removing the lymph node barriers might be harmful to our patients in case of local recurrence and second primary tumors. And these are the 3 studies that are published in the literature, first back in the 80s, and this is an Indian study in the late 80s and a Brazilian study in the 90s. All these studies failed to show any difference, although they were, as said before, underpowered, and some even had to be closed prematurely. Therefore, a proper randomized clinical trial will probably never be carried out because of the huge numbers of patients that we need to allow for meaningful conclusions. And when both arms have a difference in treatment, surgery or no surgery, I think sometimes it's difficult to convince our colleagues to enter patients in such a trial. So many have adopted a more practical approach, that they do elective treatment of the neck when it exceeds about 20%. I put a question mark behind it. Or in case the neck is entered for technical reasons, and they adopt a wait-and-see policy if it is below this 20%, and if strict follow-up can be ensured. And on what is it based? It's a general feeling, but there is one study in the literature, Weiss from New York, who performed a decision analysis back in the 90s, and he found that the 20% rule is logic when we weigh morbidity, at that time probably mostly modified radical neck dissections, against doing the patient a service. So the 20% has since then become more and more accepted in our thinking about treating the N-node neck. But when we realize that we can assess the neck by palpation only, most of the tumors, most of the sites in the head and neck, including the patients that we are thinking of today, the patients with early stage oral cavity lesions, where it's really a question should we perform an elective neck dissection, yes or no? Most will qualify for this elective neck dissection when we take this 20% rule. The vital question now is, can imaging techniques or other techniques such as CT, MRI, ultrasound, fine needle aspiration cytology, or even FDG PET sufficiently reduce this number of occult metastatic rate in certain groups to allow for watchful waiting? And this is an important question to answer. Just go briefly over some of the imaging studies that have been published in the literature from the 1990s onwards. They're all performed in very small number of patients, and they show reasonably disappointing accuracy rates. The same goes for the later studies, CT, with one possible exception of ultrasound-guided fine needle aspiration cytology, which shows a reasonable sensitivity. Of course, this is almost as high as you can get it, because you will always miss micrometastasis. But here, a sensitivity rate, initial sensitivity rate of 73 was found. But I think it's fair to say that we remain at an impasse with any imaging method currently as to staging with the clinically and not neck, because we always miss micrometastasis. It is not so difficult when it's clear. We see here two MRI sequences and here a PET image. Here we can see a tiny lymph node of less than a centimeter, which was not palpable but clearly visible on MRI and PET scan. But that only goes, of course, when there is sufficient amounts of tumor present in a node, and that the primary tumor does not shine through the node, which can be very close. This is the possible exception, not only an imaging method, but combined with cytology, and this is the ultrasonographer at work, where he can exactly see where the needle is in the lymph node. He can move it around a wee bit and then is able to aspirate a good sample, a representative sample out of this lymph node. What are our options then towards the clinically and not neck? We can irradiate it, we can do surgery to it, or we can observe based on our risk assessment, as we have just talked about it over the last couple of minutes. And that leads us to a more personalized approach based on predictive markers, which is in line with the lecture by Greg Wolf. Everybody is moving now to personalized approaches and not on general approaches which are suitable for the average patient. The management of the neck, of course, also depends on the treatment of the primary, and that is an institutional policy. Elective neck irradiation is a good treatment. It gives greater than 90% control rates, but it also gives significant side effects, fibrosis and xerostomia. And we lose one treatment option for a relatively small tumor in case of further tumor recurrence or second primaries. It is, however, especially in northwestern Europe, applied in laryngeal and pharyngeal tumors, which are almost always treated primarily by surgery. And this is the surgical approach. We can do a level 1 to 3 neck dissection, in this case also 2 BIVAs dissected for an oral cavity lesion. Nowadays we probably will not do that anymore. And this is the lateral neck dissection, 2 through 4 for a laryngeal primary on both sides. What should we aim for? We should aim for these figures in these ranges as to neck recurrences. That is 2 to 3% recurrence in the PN not neck and about 10 or less recurrence percentage in the PN plus neck. This is what we obtained in doing complete neck dissections back in the 80s, but of course newer treatments should aim at similar success rates. The efficacy of selective neck dissection has been reported over and over in the literature lately, is indeed in the order of 3% recurrence in the PN Nord neck, but a little bit on the high side maybe in the PN plus neck. And that's the reason that most authors advise post-op RT if multiple nodes or extranodal spread is present also in the selective neck dissection. Although these procedures, just like to add, were devised in the non-treated patients in the irradiated neck, these also seem sound. So having said this, we now come to the more patient-tailored approach, that is investigation and observation if the investigation is negative. And then we can think of the sentinel node investigation, we can think of ultrasound-guided fine needle aspiration cytology, and we can think of characteristics of the primary tumor, both clinical and molecular. The sentinel node concept is based on the premise that the tumor spreads via lymphatics to the primary node, and that examination of this primary echelon of nodes directs our further surgical treatment. And this is graphically, the tumor is here injected at its surroundings, and then this is shown to be the first sentinel node. There can be more, but this is the hottest sentinel node in this case. And this is how it's done in actual fact. Careful injections around the primary tumor with technetium-labeled colloidal albumin. And just after a few minutes already, we can see the lymph tract towards the first echelon of nodes in the neck appearing, and this can be then marked on the skin to allow for either cytologic punction or for a sentinel node biopsy the next day. And when we look to efficacy figures, I think there's only one study in the literature, the one by the people from Kennisburn in Glasgow, and I got this slide from Gary Ross and David Suter, who can reasonably say something with long-term follow-up. This is a 5-year follow-up of 134 patients that were N-node and had sentinel node biopsy, either followed by an elective neck dissection that was based on this sentinel node biopsy or without. And they found sensitivity rates in the order of 90%, and only 4 patients had breakthrough disease in this large series over 5 years. And they were actually able to salvage 3 of these 4 patients. So I think this is a nice result. Of course, this is always a first study, a study with dedicated people in one center, which usually has very high accuracy rates, but these should be then further followed up in larger series. And this is what they found: very high identification rates and very high sensitivity rates. Both are a wee bit lower for the primaries in the floral mouth, which is of course understandable when we realize that the sentinel node is often quite close to a floral mouth lesion. So we can say that it is a feasible procedure. It's sensitive. It's a wee bit less sensitive for the floral mouth cancers, but we need further and longer follow-up before we can really advise implementation into our regular day-to-day practice. There are 2 ongoing trials using sentinel node, one in America, which is more or less a validation study because always a neck dissection is being done. And in Europe we have the sentinel node European trial, the SEN trial, which does not require elective neck dissection when the sentinel node is negative. We participate in the study, and we have already found very interesting results in the sense that we encountered level 4 nodes in anterior oral cavity lesions in an area that we would probably not have dissected if we would have done a selective neck dissection. The second approach is the ultrasound-guided fine needle aspiration cytology, which is a bit of a hobby horse of ours in Amsterdam, and therefore I will go into a little bit more detail here. This study entailed small oral cavity and a few oropharyngeal lesions that were amenable to transoral excision. The pre-op ultrasound should be negative, and then a wait-and-see policy was adopted for the ipsilateral or bilateral neck sides. No post-op RT should be required, because then, of course, we can't calculate the recurrence in the neck anymore. And also, and this is very important, the same method was applied at regular intervals post-op. We included at that time 161 patients, that about half of them had negative ultrasound examinations, so no cytology was required, and the other half had cytology of one or more lymph nodes in one or two necks, which were negative, and therefore a wait-and-see policy was adopted, mainly anterior oral cavity, as you can see here. And this is the T-stage distribution, about 2-to-1 distribution, T1, T2. And these were our results. 34 patients developed neck metastasis later on, which was either clinically or ultrasonographically detected. And of these patients, and this is in the order of the famous 20%, as we can see here, of these patients, about 80% could still be salvaged by neck dissection plus or minus RT. And I think these are figures that can stand up in the literature against other studies that use palpation only. And this is when they occurred, all of them occurred within the first 2 years. And this is the T-stage distribution of the patients that had this failure in the neck, the same 2-to-1, so no bias as to the extent of the primary in 2 dimensions, that is. We did not take depth into account here. And this is also a very important slide. This gives the results of the time interval between the primary local excision and the neck recurrence, which is very early on in the disease process. So by doing these repeated ultrasound-guided fine needle aspiration cytologies, we are able to salvage our patients at a very early stage, much more quicker than we would have done when we have used palpation only. And here we see the size of these metastases when a therapeutic neck dissection was being performed, seemingly very or reasonably small lymph node metastasis. And this is how it compares in the literature. Here are our figures: 21% neck recurrence and 80% salvage rates. When we compare that with a weighted average of the literature, it can stand out very clearly, and especially the salvage rate. When we use palpation, we can come only to about 50% salvage, and when we use cytology or ultrasound-guided fine needle aspiration cytology, we can reach figures like 80% salvage rates. Are we doing our patients a disservice by waiting until the node develops? I don't think so. These are the patients that had lymph node positivity from the start on and were, of course, given or treated with a neck dissection, and these are the patients that got a delayed neck dissection. I don't think we did our patients a disservice. What is the cause of the false negative results? We can aspirate the wrong node, and we can also aspirate a wrong part of a node that contains only a tiny metastasis. Therefore, we adopted also the Sentinel node concept to this cytologic workup, fairly similar to what we have seen in the Sentinel node biopsy studies. We used 39 patients with very small lesions that were all not, and we did the Sentinel node procedure combined with ultrasound, and then adopted a observation policy amplified with the ultrasound, and these were our results. We were able to find the sentinel node in almost all patients, either by the regular method or by measuring the radioactive counts in the residue after we have done a blind cytologic intervention. The results in terms of recurrences are not better, even a little bit worse than we found without sentinel node in this sense, and therefore we concluded that the sentinel node directed ultrasound guided biopsy is not capable of improving the detection rate, and therefore we abandoned this method. Thus, the most likely cause of false negative findings is that we aspirate the wrong part of a node that contains only a very small metastasis. And indeed, it has shown by Van der Brekel already back in the early 90s that of the neck dissection specimen that were N0 but proved to be PN+, about a quarter had only very tiny metastasis, and therefore it is practically impossible to obtain sensitivity rates by any of these methods above, let's say, 75%. We can also take clinico-pathologic tumor characteristics into account. Superficial growing tumor will probably not metastasize that quickly towards the neck nodes, and a thicker one will, but are we looking to thickness? Are we looking to depth? What is the cutoff point? There is surely something in it, as has been found by the people from Kennisburn here. The thicker the tumor, the more occult metastasis will be found in the neck. But clinically, this is a very difficult criterion to use whether or not to treat our patients electively. Another fairly late addition to the characteristics of the primary tumor is the expression profile, the molecular profile that can tell us whether a tumor is going to metastasize, yes or no. And this is a landmark study by Roepman and al. From Utrecht in the Netherlands, a single center study, but still I think it's important that we all are aware of this. This is their heat map of their expression array of their different genes. Here we have the clinical and the pathologic findings, and they were able, this is their training and this is their validation figures, they were able to find some cutoff points below which a tumor will probably not metastasize. And they found accuracy rates for N0 of about 100% and accuracy rates for N+ of 77%. Of course, we always have to question ourselves, are we looking to negative or positive predictive values if we take the stand that everybody gets a neck dissection provided that these examinations are negative. I think we have to look at these figures. If we say we only perform a neck dissection if it's really indicated, we want a higher value here, higher than, let's say, 77%, because that would still mean that 23% is treated wrongly. What improvements could be done on this study? This study included also oropharyngeal lesions and also patients who were initially N positive, and of course sensitivity predictive value rates differ if the population differs, and we especially want to see the accuracy rates for the T1, T2 clinically N0 oral cavity tumors. We also know that HPV-induced tumors, 10 to 20%, have a different expression array than the ones who are not HPV-induced, and therefore this should also be taken into account. This had routine histology, no step serial sectioning, and no immunohistochemistry. Some were very old slides, had very old RNA, which could not be used very well, and it was single center, as you heard before. So if And this study is presently being done, taking a few of these items into account. This could either be a positive or a negative effect. We still have to wait. But I think it's important to note that there is something into characteristics of the primary that can tell us whether a tumor will metastasize, yes or no. This was on RNA. There's also a DNA method, microarray CGH, which is not dependent on old or new DNA, so we can do it in hindsight on our slides stored in the pathology laboratory, and there are also on the DNA level, there are certain characteristics which can tell us whether the tumor has or will metastasize, yes or no. Proteomics, another thing in the realm of the future. If it works, it's very easy to use because we can just do some immunostaining on the primary tumor, and then we could see if a tumor is metastasizing, yes or no. Maybe this will work in the future, and this is even more into the future, massive parallel sequencing. We can send the tumor to our laboratory, the whole genome can be sequenced, and then we could maybe in future get an indication whether it is an aggressive or a non-aggressive tumor that yes or no will metastasize. The discussion, just to round off, the figure of 20% that was found back in the 90s is probably a little bit too high because we now have selective neck dissections which have much less morbidity, albeit not zero, compared to the radical and modified radicals that we were used to do until then. So it's more probably we should aim for methods that can find a 5 to 10% failure rate more than 20%. The conclusions and the prospects: currently selective neck dissection is still the gold standard, of course, and anatomic and metabolic imaging is not really suitable to bring this a priori chance of occult metastatic rate down to reasonable levels, especially not if we take 5 to 10%. There are some promising avenues towards more personalized approaches, and ultrasound-guided fine needle aspiration cytology and sentinel biopsy may be possible alternatives. A genomic signature seemingly exists that predicts nodal metastasis. And these are just some thoughts that were also derived from previous discussions in this room when we talked about selective neck dissections. Ideally, we would need a trial that compares selective neck dissections versus sentinel node biopsy. But I'm very doubtful if that will ever be a goer. The advantage, of course, is that both arms have a surgical intervention, which make them more acceptable to us surgeons. And next, we would then need a trial compared to breast and melanoma, where we can see if a single micrometastasis in a sentinel node would really require a full neck dissection later on, but that's even more difficult to perform, I think. I'd like to thank my team back in Amsterdam, who not only helped me in the day-to-day management of these patients, but also in the thinking of how to treat our AHNS patients best. I'd like to thank you for your kind attention.
Dr. Leemans, on behalf of the Milton J. Dance Endowment, I'd like to present you with this memento of your inaugural lecture. Congratulations.